And good afternoon. I'm Mary McCormick, the Executive Director of the Rotary Club of Milwaukee, and I'm glad to welcome you today to our Thursday snack program. We were running these programs every Thursday at noon, and we call it snack because it's a little bit less than what we offer on Tuesdays, in that it's less formal. We don't have an invocation or say the Pledge of Allegiance or have club business, but we will continue to offer a very high quality program. And we typically feature either a member of Rotary or a Rotary project or something that's really connected to Rotary, but also very pertinent to the way that we live and think today. Today, we're going to hear from our resident COVID expert, who we've had the pleasure of learning from multiple times in the past, Dr. Robert Gleeson. And before I turn to him, though, I want to say that next week we will have the opportunity to hear from Frank Gimbel, our fellow Rotarian, and the title of his program is Adventures of a Criminal Lawyer. A criminal defense lawyer, I guess I should say. And so that, of course, I think promises to be another terrific program. And so I'm hoping you'll come back next Thursday at noon. Today, we really are in a regular Zoom format. So I'm going to turn this over in just a moment to Dr. Bob, and everybody else will stay muted until we get into the Q&A. Depending upon how many people we have, we'll either ask you to put your questions into the chat and I will read them out, or if it looks like we have a manageable number of people that are going to be involved in the conversation, we'll let you raise your hand. So anyway, it is my pleasure right now to introduce our friend and fellow Rotarian, Dr. Bob Gleeson.
Good morning, everybody. I'm delighted to be here, although I think we'd all agree that we'd like to be done with COVID. COVID's not done with us. So I want to run through today the probably 5 big questions I get from people on a regular basis, and then open it up to your questions, because my real goal here is to answer your questions. We have a phenomenal amount of misinformation and misdirection about COVID. And one of the most important things in the CDC manual about fighting a pandemic is that the message has to be consistent, it has to be scientifically based, and it has to be repeated over and over and over, so that everybody understands that wearing a mask is no different than wearing a seatbelt. So let's start now with talking about the pandemic across America. We know we have a terrible problem in America. We're one of the worst performing countries. But throughout America, there's great differences in how bad the pandemic is. One of the ways we're going to look at it is cases per 100,000 people. So our goal is going to be to get to about less than 5 cases per 100,000 population. Okay, keep that in mind. What I want to go to first is from the Wisconsin Department of Health COVID page, which in Wisconsin, by the way, we have really good numbers. They're accurate, they're reliable, and they're collected consistently throughout the state. We really should be very proud of that. It's not that way in all states. So Michelle, could you go to that first table? So Michelle put up, and I just copied and pasted this to make it so we could make it a readable font size. But this is, we have 66,830 total cases in Wisconsin. Of those, 8% or 5,000 have been hospitalized. I encourage everybody to find your age group, find the age group of your children or grandchildren, and find the age group of your parents, and look what percentage of that age group was hospitalized. Michelle, next one. So now we're going to look, and this again is still from the Wisconsin Department of Health, at the number of deaths in Wisconsin, and we've had 1,000 deaths. But now you can look at it. Remember that the chart above showed you the number of cases and the percent that went to the hospital. Of the people who go to the hospitals, where most of the deaths are going to come from, some died at home, but not many, And you're going to see by age group that 9% of all the people who were between age 70 and 79 who were admitted to the hospital, and a third of the people in that age group who were infected were admitted to the hospital, died. So these are big numbers. And when I had to go run an errand at the Brown Deer Golf Course recently, and I was shocked at the number of retirees with not a mask around who were gathered in tight groups, talking freely. We'll talk about that in a minute. So remember, so that gives you a feel for why we are concerned about this pandemic. This infection is real and it kills people. We're now starting to understand that we have a group called the long haulers who were infected 3, 4, 5 months ago, and they still haven't recovered. And some of them are quite ill with this prolonged disease of severe fatigue and things. Now, the next, you have both these links in your email this morning. Michelle, go to the next group of data. This comes from, keep going, one more. Let's look at, stop, here we go. Let's look at, remember when I said that we wanted to be cases per 100,000? We want to be less than 5. So there's New Jersey and New York. New York, 3.5, New Jersey, 4, Wisconsin, 13 cases per 100,000 people. Before the program, I was talking to Mary. Her daughter lives in southwestern Oregon, and they have 0.5 cases per 100,000. I would argue they can open their schools, they can go to the bar, they can have a crowded church event, they can do whatever, because they basically don't have any disease. They have to be a little careful because people from out of town and things. But we're nowhere close to where we should be. New York and New Jersey can open up more freely than we can. Down a little bit, Michelle, please. Okay. Is there a little bit more? Well, let's go here by county. We're good. So this is still the New York Times. You click on, and by the way, this is not behind a paywall. Anybody can get to this. You click on the graph that says, it's a little chart of the cases since the start of this pandemic in Wisconsin. You click on that, then you click on by county, and you click on per capita. So it's per 100,000. It's pretty intuitive. And I pulled out Washington, Waukesha, Milwaukee, and Ozaukee County. So Washington County has 21 cases per 100,000 people. To put that in context, when Florida was bad, they were running about 48 per 100,000 people. These are big numbers, folks. Let's not pretend this is a nothing. Waukesha is 19.3, Milwaukee County 17.3, and Ozaukee's 13. This is really important because everybody in the North Shore and the far west side thinks this is somebody else's problem. This is somebody else's disease. And yeah, essential workers, and I'm thinking bus drivers who don't have enough PPE, who go home and live in a house with 6 other people in one bathroom. And Jennifer talked about that problem when she sees these COVID positives in her clinic. Yeah, well, they think about it as their problem in the inner city. Look at the numbers that we have. This is an explosion waiting to happen in the outlying counties, as far as I'm concerned. And I think we're going to see some real disease, a much more disease than we've seen. Okay, Michelle, I think we're good then. You can switch back to me. You know, to date, only about 10%, maybe it's somewhere between 8 and 15% of Americans have been infected. That means that 90% of us have not been infected. So how do we think about this? Just because you haven't been infected, just because you don't know anybody who has been infected, simply does not mean that you're magically immune. So think of COVID as a forest fire. Where the fire has burned, i.e. somebody got infected, it won't burn again. They're not going to get infected a second time. But everybody else out there is dry timber to this virus. And the virus simply doesn't care about us. It has a different timeline. It has a different purpose. And that purpose is to infect us. So we're all susceptible. One of my neighbors, he's 72. His daughter is a physician. They visited their daughter. 2 days later, the daughter called and said, I tested positive for COVID. The mother, our neighbor, tested positive and got sick for 2 days. Her husband, Paul, went to the intensive care unit 2 days later and stayed there for 7 weeks on a ventilator with dialysis. Now, by all rights, he should have died. No 72-year-old survives like that, but he did. And he now is back home trying to recover, and it's a long haul. But they were visiting their daughter who was taking precautions, and this thing happened. So what do we need to get out of this? Everybody says we need a vaccine. I don't, trust me, I want a vaccine, I want treatment. I actually think we're going to get out of this quicker with a rapid test. Now, I don't even, the rapid test that we're talking about is not as sensitive. So it's going to have some false negatives, right? People who are infected will still get on, we'll test them, and there may be somebody who's infected and we're still going to get on the airplane. Call it 80% sensitive. Over time, it will improve because science has a way of improving all tests. But imagine if you could do a rapid test, 15 minutes, with spit. You spit in a tube, and within 15 minutes, you can get a test that's going to tell you if you're positive or negative. It's pretty good on the positives, 80% accurate on the negatives. So now you can get on the airplane and you will know that everybody on the airplane and everybody in your airport on the other end has tested negative, because it'll be a universal requirement to get on an airplane or to go to church or to go to a wedding. It also means that if you test positive, we're going to say, no, you can't get on the airplane, or no, you can't come into the restaurant. And furthermore, you have to have a confirmatory test, and which is going to take 2 days, and you need to go home and isolate. Not sort of isolate. You need to go home and go in your room and close the door. And people need to bring you food, and you use your own bathroom, and you don't share anything, because that's what it means if you're infected. But by identifying those people, this is basically what Korea did. Korea has had a grand total of 500 deaths. I mean, it's crazy, you know, the number of cases and things that we have compared to the rest of the world. But this is how they did it to stop the disease. You identify people who are positive, and you quarantine and isolate them. But more than that, it also says if you have this rapid test and you can get into the airplane, or you can travel, or you can go to work, or you can go to school, think how much safer we would all feel. So I'm thinking this rapid test that we're talking about is really going to help us. It may help us more than the vaccine, because vaccines are not simple. And this idea that we're magically going to have one is hooey. Magically have one by the election is hooey. A vaccine, now the fastest vaccine we've made before this was measles, which took 4 years. But we've made phenomenal progress, both because we're building on the technology we used for Ebola vaccines and every other vaccine we've made. We're building on that to make the new COVID vaccines. And the companies have all been funded enough so they can go crazy on ideas. There are people who are trying to modify the measles vaccine. There are people who are trying an RNA vaccine, that's Moderna. There are people who are creating the virus vaccine. There are all kinds of things going on. But each vaccine requires a trial, a phase 3 trial of 30,000 people. Half get the vaccine, half get placebo. Now you have to give them a second injection in 28 days. And then the clock can start. Then you start your 90-day trial. So now we're already in October before we're really going to be getting to or start our 90-day trial. That's why I say we aren't going to have anything by the election. Or you wait till you have 150 people infected. Of those people who get infected, so let's say you have 150 in the trial, then you go back and say, were those 150 people in the placebo group or were they in the vaccine group? And how well did the vaccine work? We have to have a vaccine that's at least 50% effective before we give it to people. So you can see the problem in waiting to gather the data. Now, all of the participants in the study will be followed for 2 years on a monthly basis. Blood drawn, looking for side effects, all kinds of things. Remember the swine flu vaccine? What did it cause? It caused a neuromuscular problem that put 450 people on a ventilator. It occurred about 1 out of every 10,000 people. But you have to give a vaccine to a lot of people to find that kind of side effect. So we really won't know the side effects for quite a while. Furthermore, pregnant women and children are the last to go into vaccine trials. So we won't know anything about giving this to children for a long time. Now let's talk about Moderna because that's moving quickest. Moderna vaccine has to be stored at a temperature of minus 94 degrees Fahrenheit, minus 94, until the morning it is administered. So you're not going to give it to a doctor's office. You're going to have facilities that give it, and we're going to go to the facility. And once you open the vial goes bad in 6 hours. So you have 6 hours to use what's in the vial. Now, FedEx and UPS are both building freezers that go down to minus 100 degrees. And those freezers are built to go from the factory where the vaccines are produced in the vials onto a truck, into an airplane, onto a storage facility, and then sent around the world. So Moderna is going to have this vaccine that is going to be difficult to give it to people. And that becomes a problem. Furthermore, you have to find out, does the vaccine, how does it handle with the glass? Does it interact with the glass or the stopper? Does it maintain its effectiveness throughout the whole life cycle? And so when we first give it, it will come in a multi-dose vial. And it will be a pure glass. But everything else, as it goes down to individual doses or vials, it's specially coated and treated glass and stoppers. And all of those have to be tested to be sure they don't interact with or any part of the vaccine. We want the vaccine, when it's given 2 weeks later, to be as effective as it was the day it was made. And so there's all those kind of things. Everybody's going to have 2 shots of the Moderna vaccine. So now in America, we're now talking about 700 million syringes and vials and all of the equipment that goes with that. We're talking about where's this going to be administered. It can't be given in a workplace because we're not in a workplace anymore. We're at home. So you can see that vaccines are going to be big problems. What's going to happen when we open schools? This is actually pretty quick. We're already seeing the answers to that. We're getting infected kids, and we're going to get some infected adults and some infected teachers and some infected parents. There's almost no way to avoid schools causing infections. And so it becomes a matter of balancing the risks. We know we need and want kids in schools. They learn better. They need the socialization. It's important to get some of the kids fed and those kind of things. So I'm actually quite worried about schools, but I totally understand wanting to or needing to open up schools. So my last point is, what can I do to keep myself and my family safe? We're not going to have a vaccine, and when we have one, it's going to take 6 months to administer it, and to get it distributed. And then we have the whole questions of who do we give the vaccine to first? And are there age cutoffs above or below where we won't give the vaccine? So I want to talk about what we need to do to stay safe. And we need to do the things today and in the future that we were doing in March and April and May, when we were more cautious about socializing and we were more cautious about going to the grocery store. And we're actually doing a better job of wearing masks now than then. But we need to continue to wear a mask. A mask is no different than wearing a seatbelt. Why some kid who told an adult, you need to wear a mask, it's the requirement of the park where you're in, and this 39-year-old man belted this 17-year-old kid and shattered his jaw because he told him to wear a mask. I mean, this just has to stop. It's no different. Nobody's taking away civil liberties than wearing a seatbelt, and we all wear seatbelts. We don't smoke in restaurants because these things have become socially unacceptable. We need a message, nationwide message, the importance of wearing a mask. It can't be sort of iffy. It's put on the damn mask. So always wear a mask. Avoid large gatherings. You don't eat inside right now. I mean, we're going to be bundling in sweaters and thermal underwear to eat outside in November, probably, because that's going to be safer. It's going to be hard to get a lot of people inside restaurants. I don't go to churches. I won't go inside events like that. But that's where it's really spread. If you have somebody in a church who's infected and singing and you're all sitting together in the room, and the person who's singing loudly or badly is infected, that's a really effective way to put a lot of virus out, and you're just sitting there surrounded by it, and that's like the worst situation you can do. So be smart. Eat outside. You can socialize. Have friends over. Have a cocktail in the patio with your next door neighbors. Wear a mask and wash your hands. It's pretty simple. But we will do a great job. Look what New York did when they had that terrible infection problem in early March or early April and May, and they brought it way down, and their numbers are much lower than ours because they paid attention to this. And before I open it up to questions, I want to say to Tom, I gave this talk to you. You're on the bottom of my screen, and you're the best listener I've spoken to in a long time. You're really looking at me, concentrating and taking notes and writing what I'm saying. So thank you. You were very easy to talk to. Okay, questions, Mary? All right. I lost Mary. I'll go.
No, I'm here. No, I'm here. I just was, we have questions in the chat, and I'll read a couple of them, but I think we have about 30 people, so people can also feel free to chime in. This is from Bill Sheehan. My primary doctor told me yesterday that the new guideline is 7 to 10 days for self-quarantine in advance of traveling to visit relatives, including a new grandchild. Do you agree?
If you're not infected, I would agree with that. And that's down from the 2 weeks. So that's an improvement. But what you're trying to do is limit the risk that you're going to give it to a new mother and child. And so they're asking you to stay away from crowds. I don't define that kind of quarantine that strictly. It's not as though you need to be in your room with somebody bringing you food, but you need to not be stupid. You're not going to go to a crowded place. If you need groceries, I mean, I've been known to drive to the grocery store and leave because the parking lot's too full. I'll go back at 7 at night when there are 6 people shopping in Sendix in Mequon. And then I'm pretty safe. But I won't go in and I was in a store the other day. I went to Pete's to buy, we're making peach cobbler for some sick people. And I went to Pete's to get the peaches, and I had walked out because there was a line at the checkout counter. There were 4 people in two aisles there checking out. And I said, I don't want to wait in that line. Everybody was wearing a mask. Everybody's very nice. I just didn't want to wait in the line.
Okay. Let's see. if people can be asymptomatic, shouldn't everyone get tested?
Well, they should if we could get tests. Part of the problem is we have such a test backlog that we don't have the testing capacity to handle that many people. That's why a cheap, rapid 15-minute test, even though it may not be as sensitive as a really good test, is probably what we need. We need good enough, not perfect. Then we can start to test everybody. I happen to be one of the people who thinks we should be doing 5 to 10 million tests a day in America. I mean, before anybody goes to work in the packing plant, everybody who walks in the door should have a rapid test. That's the only way you're going to stop fellow packing plant workers from becoming infected.
If people can be asymptomatic, sorry, read that one. Do the rapid tests give a positive result if you are asymptomatic or pre-symptomatic?
Yes. All it's looking for is the virus. It doesn't look for symptoms. By the way, I happen to think the best test is probably for finding out whether you're infected, is can you smell? I've had people tell me, I'm sure I had this disease in February because I had a really bad cough and I was sick. And I said, could you smell? And they all say, yeah, I could smell fine. I said, then you didn't have COVID. The smell test is really good for COVID. I think it's actually better than temperature.
Okay. I think you probably answered this. This is from Jeff Martinka. Can you describe how family or friends can gather under COVID as safely as possible? And I think you probably talked about getting together outside. Do you want to expand on that at all?
This is really hard. We have 2 daughters and sons-in-laws and 4 granddaughters who live in Milwaukee and a son who lives in Chicago. I don't know if we're going to get together for Thanksgiving. I don't know that we'll all feel comfortable doing that. We will gather with parts of our family, kind of separately, not bringing everybody together, because it just feels funny. All the adults have activities outside the home and their works that expose them to lots of people. And so, that I'm okay with a small bubble. It's their bubble that I worry about. If I'm okay seeing them, and if I got infected because I saw my daughter, that's one thing, but I don't want to infect lots of other people in my family. So I would keep the numbers small for family stuff. I would keep it outside. I think it's very hard to keep families separate because you want to hug. Heaven forbid you have granddaughters under the age of 10. They don't know about this no hugging yet. That's a concept foreign to them. But you gather around a table for food or a drink, and all of a sudden you've got lots of community closeness, and that's where things get kind of iffy to me. So I keep the group under 10.
Okay. Chris Hendricks says, have you seen the Georgia Tech site that purports to tell the chances by county of encountering someone with COVID by size of the group? For example, in Milwaukee County, they say 98% for a gathering of 100 and 96% in Waukesha County. So if I understand this, this is saying that if you go to a group with 100 people, there's a 98% chance that you would come in contact with someone with COVID.
That's the way I heard what you read.
Okay.
I would love to see that link. That's just mathematics. That's pure mathematics, because we know how many people get infected by it. How many people one infected person can infect when they're with people, particularly indoors, and let's say for longer than half an hour. But there are probably a couple of constraints like indoors and over some length of time.
Well, I'm sure Chris will send that to you, but she said it's a Georgia Tech site. And Teresa Regan has another question. When do you anticipate the saliva test to be available?
Next month. I think it's coming very quickly, and it's going to be relatively easy to produce. It's going to be cheap, maybe around $1. So I think, and then it'll be a matter of scaling up the production, because if you're running a business or a school and you want to test every student at your university every week, you're going to need 50,000 tests if you're University of Madison.
Okay. And Tim Hunter shares that I like the analogy that a person with COVID is like a lit cigarette in a closed room.
Yeah,
So.
That's a really good analogy. And what that gets at, it's a great question, is this idea of aerosolized spray. So we used to talk about droplets, big droplets, and droplets go out and they fall to the ground, and they're in the air for maybe up to a couple hours. The thing about aerosolized, the image is cigarette smoke. If you don't smoke and you walk in a room, you can see when somebody smoked. You can smell, rather, when somebody smoked. Was there an hour ago. Well, it's the same with COVID. If you walk into a closed room and somebody was there an hour ago with COVID and they coughed or sneezed, they're aerosolized particles. Think of the little dust stuff that you see floating in the window when the sun is right. Is still in the air. Now, there may not be much of it, but there could be enough of it.
Okay. That's all I have in the chat, and we're at about 30 minutes. But so I'm going to thank you, but also I'm assuming that you're still willing to stay around if people have other questions and continue this conversation. And I would say that we can just be in gallery mode, and people can just raise their voices.
Absolutely. Take it.
Looks like Darren do you have a question?
I have a question.
Hi, Chris.
Another question. Anytime, will the saliva tests be available for, say, home use? Like a pregnancy test, will it be available for home use anytime soon?
I think that's going to be dependent on ability to scale up manufacturing and distribution. Under normal circumstances, I would say getting to where we need 10 to 20 million tests a day in America is going to take a manufacturing company quite a while to build the factory and the facilities or convert an existing thing. So I think it will be months before they're available for home use.
Chris Martinsek just put something in the chat. Dr. Vin Gupta stated that false negatives are way more common than false positives using the current rapid tests. Is that correct?
Well, there's so many tests, and there's so many, I assume we're talking about the virus test and not the antibody test. I don't know, it's sort of test specific. I am less concerned about false negatives. As I said, right now we're running about 90 sensitivity, which means you're false negative, of about 90% with the tests. 10% is a big number in the testing world. The rapid saliva test right now is going to have a sensitivity of 80%. which means that 20% of the people who are really infected, we're going to tell them you're negative, and they're going to go into the church. All we're doing with this rapid test is trying to reduce by 80% the number of people who are infected that we come in contact with. And for most of us, that's good enough to get back on an airplane.
Steve.
Dr. Bob, speaking of masks, as a practical matter, what's the best mask I
What
should
you're
be
wearing
trying
now
to
is not a good mask, Steve. What's the best mask to wear? The mask that you wear. Not the mask in your pocket, not the mask at home. The best mask is probably this version of the N95 that is available. The true N95s are not available for us. We still need to save those for first responders. They also fit differently and they're very tight. I don't know if you've seen some people with the scarring or the bruises around their face where they wore the masks because it was so tightly fit. The second best is probably going to be those 2 or 3 layer cloth masks that fit well, where you insert basically a kind of a coffee filter, and that's what you replace periodically, and then you can still wash your mask. Let's talk about a couple of the really bad ones. The commercial ones like for industrial use that have that vent on the side, droplets and aerosolized stuff still exits that. They'll keep you from getting something, but they won't stop you from infecting other people. Another bad one is a simple bandana. And they're now saying that those cloth gaiters that people pull up may actually be worse because more droplets are being aerosolized through the thin layer of cloth. So I would say that the triple layer cloth ones, the N95 ones, and a good paper one that you put on and sort of press around your face. The mask also has to be worn over your nose and your mouth. Wearing your mask on your chin doesn't do any good. Lots of people walk around with their mask on their chin. So you need to wear it right. I do not wear a mask when I'm outside bicycle riding. I don't wear it when I'm walking. I have it in my pocket in case I see a neighbor and for whatever reason we're going to talk and have to get close together. But in general, drive around your neighborhood and we see people talking. They're all standing 6, 8, 10 feet apart today. And you know, the neighbors who are meeting at the end of the driveway are still 10 feet apart when they're talking. We always used to stand next to each other, but we're getting used to keeping a distance. And that distance is enough outside that we don't need to wear a mask. I do wear a mask in a restaurant unless I'm eating. So we went to eat outside at Bartolotta's, and the rule was you had to have your mask on or the server wouldn't come to the table. So the server came over to take your order. Everybody had to put on a mask, and that's protecting them. You're wearing the mask to protect other people is your primary purpose. And I thought that was a really nice gesture by Bartolotta's to keep their workers a bit safer.
Jeff Martinka asks, I have masks with a built-in slot. Did Dr. Bob just say we can add a coffee filter to improve them?
Yes, yep, that's what that built-in slot is for. The coffee filter, they actually make a filter you can put in, but the coffee filter will work quite well.
And Chris Martinsek adds that I was just reading that Scott's Blue Shop disposable towels are very effective, as are some vacuum cleaner bags. I think my friend of mine made one for me that has a vacuum cleaner.
Yeah, I've heard of
furnace filter
vacuum
or
cleaner
something.
bags. I understand they're quite hard to breathe through, though.
But anyway, so
wouldn't we all like to be done with this? This virus, it's going to take a while, even with the vaccine and rapid tests. Fall is coming. I need to tell everybody, fortunately, we still have all participants on the line. Be sure you get a flu vaccine this fall.
I just got 2 big patio heaters, so we're going to stay outside until Christmas. But
I bought mine too, Mary.
I think Tim Hunter has something to say.
Yeah, I know you've been saying that testing's really hard to get, but I've gotten tested twice down by Chuck E. Cheese down there. You know, down on Chase Avenue. You know, drive-up testing. It's in and out in 15 minutes, and I got my results in a day or two. It worked really super.
You were
well.
lucky.
You were lucky.
I mean, that drive-up facility there that they've got. I mean, the lines aren't very long usually, and you just go in and out. It's, you know.
The first test I got, it took 15 days to get it back at CVS.
Yeah, well, I've noticed that from the first time I got my test I just got tested last week. They've improved their system, so now they have you sign up on your phone, and it's much more electronic, and then you get an email with your results within a day or two. I mean, they're doing a good job down there. I think
that's great.
It's pretty quick. So.
And Darren, do you want to hop on?
Yeah, thanks, Dr. Bob, for continuing to do this. This is fantastic to have your expertise in this personal way. You know, we as a club have decided that we're going to come back to in-person meetings potentially even starting early September. And I just want to hear from you, you know, how do we best make this experience work for those who want to make the decision to come in person? You know, how do we make it as safe as possible? Again, you know, I'm thinking in my mind of, you know, if this is going to be the event that I come to, and I'm willing to do that, I'm thinking personally, you know, I'll make the decision to not go to other events or engage in other outside of work activities in an effort to sort of minimize my overall bubble, if you will. But, you know, what advice can you give us as to how to make this, you know, as safe as possible for the membership?
Well, I personally will not attend. And I don't know that I have a idea on how to stay safe when you have 75 people together in a room for an hour, hour and a half. I don't, other than maintain your distance, keep your mask on. I tend to think people won't do that. I tend to think Rotarians will be a lot like second graders when they go back to school. There'll be lots of shaking hands and lots of, or wanting to shake hands just because that's our inclination, and there'll be lots of that. I don't know that you should. I'm glad we don't sing in this Rotary. Some Rotaries sing. That would be one thing I would say they shouldn't do. But I would put food on the tables. There is no buffet line, even though everything will be pre-boxed. You don't have people pick it up. Just anything I could do to reduce congregation. I may stick my head in to see how it looks, to see who is seated, you know, how does the room feel? I will say that the War Memorial has done a really good job of air filter, speed of ventilation, the HVAC system. On the good side, it's a big room. It has a high ceiling, and it has, I don't know how quickly room airflow turns over in the room, but it's a pretty darn good HVAC system. So I'm impressed by that. Was that helpful, Darren?
It is helpful, right? You know, as we look to balance, you know, the wants and needs of the folks to have a virtual option, and those of us who want to make the decision to come in person, again, to just create a space where that is as safe as possible. And I think to your point,
yeah,
you know,
it's different than there's a restaurant in Thiensville that's quite busy with, and the tables are not socially distanced, and not many people wear masks. And those same people may want to come to the club, and that's not really what we want. You know, we want to ask people to, in the way you are saying, I need to, if I decide Rotary is a key event for me, how do I do it, and what other bubbles do I give up, or how do I limit my exposure elsewhere? And that's really what I think we have to think about.
Yeah, I think to your point, and what I was trying to get at earlier, right? Like, you know, I have not eaten indoors at a restaurant
Me either.
since March.
I really miss it too.
Well, yeah, of course. And I think everyone's, you know, really struggling with, you know, finding ways to connect and make relationships meaningful and reinforce that. So I certainly get that. And so as an example, like, you know, personally, I will not go to an indoor restaurant because I would value my experience in person at Memorial Hall more, right? So I think, you know, having those ways of, you know, highlighting the example that you gave, you know, if there's restaurants that are not doing it well and you would rather participate in being at Memorial Hall, you know, make the decision to go do that. And, you know, I think there's small key ways that you can highlight that make this experience more meaningful, and you kind of, you know, rate that tiered experience level, you know, to your point. But so it is helpful.
By the risk you're taking. We've all read about these large church events or the crowded bar parties. I mean, those are just foolish, these fraternity parties. And the 1,000-person church event in California 2 weeks ago. They're going to have bad outcomes. We're going to see a lot of cases when the football season starts. I don't care. I'm less concerned about the players than I am the bar the night before and the night after, because they're going to be
Sure.
kids. So Rotary has done what they can to reduce the risk, and they should be applauded for that. But we all have to decide what level of risk we're comfortable with.
We have one more question that popped in here from Bill Coleman, and he's saying, did you say the saliva test results are instant?
15 minets. If you define that as instant, that's instant. That's 15 minutes is instant compared to Mary's 2 weeks.
Right. That's right.
But I think it'll be good enough, for example, that before you get on a plane, you would have one of these tests. And then, and airplanes are pretty safe. They're calculating your risk on an airplane is somewhere around 1 in 4,000 a day to fly. So if we could reduce that, that everything's moving toward wanting to open up and wanting to do more things, and this test is going to help us do that.
Terrific. Tom Gale, you usually have a question. Not today. He answered them all already.
Good. Okay, if anybody has questions, you know you can email me. I've gotten some from members about, I visited my father and he had COVID in the nursing home. What kind of risk do I have, or when should I get a test? So I'm happy to answer those because it's part of information. So you can use my address that's in the directory.
Thank you, Dr. Bob. Are you back in Milwaukee now?
I am.
Okay.
Well, not for the weekends, but right now I am.
Okay, well, good. All right, okay. Well, good to see everybody today. Thank you again for leading a very good conversation. And that we were looking at that New York Times map last night, and it's really very, very good. I was saying to Dr. Bob that where my daughter lives, their case rate is less than 1 in, it's like 0.5 in 100,000. So maybe we should all move to Coos Bay. But goodbye, everybody.